Just to say, I'm really pleased to be here among such a rich panel to look at how to put people at the center of healthcare. I will look at it from two broad dimensions. One, our experience in SFH, what we've done, what we've learned, and what we see in the future. In addition, I'll also look at the big things that needs to happen at the sort of health system level if we are truly going to put people at the center of healthcare in Nigeria. For us, in the Society for Family Health, a key element of our DNA is the whole idea of using the efficiency of market to deliver public good. And that means that right from inception, we don't talk about people, we talk about customers. And it's our duty to truly understand our customer in the full ramification of that word. In every single thing we do, we create archetypes. And those archetypes give us very rich insights, which enable us to understand their lives, their issues, their experiences, their challenges. And depending on the context, the archetypes have different names. It could be an Amina. Amina may be a young girl who wants access to family planning. Amina may be a mother looking out after her family. But for these different customers, their needs are different. And they do have an option, and that's one thing we learn very quickly once you come from a business lens. We as health practitioners may not agree with those options, but they do have an option. And from this insight, over the years, we've actually grown a very rich understanding, which we cluster around what we call the 4 P's of marketing. For example, we know with our Aminas that when we look at products, the way they see products, the products they value are changing even as we healthcare workers sit and debate. We are seeing increasingly the need, the requirement, the desire for products, for services, for technologies that they control themselves. I'm sure for many of us in this room, some of the big things in the last couple of years, rapid diagnostic tests for hepatitis, for malaria. You cannot test for malaria at a PPMV level. And these are sort of groundbreaking. We are hearing about things like self-controlled injections like Cyanopress. This is where, if you talk to Amina, she's looking at her product, that's where she's going. Then the second thing is placement, which is also a very big issue. Traditionally, as healthcare workers, we like the idea of facilities. But actually, for us in Society for Family Health, in the last 20 plus years, we worked extensively with PPMVs. These are the sort of patent proprietary medicine vendors who are actually at the community level. And for many years, the former healthcare system could never accept them because we saw them as they can't be part of the healthcare system. But the insight we got from Amina is very clear. That is my doctor. That is the guy I go to. What most of us don't sort of recognize for as healthcare practitioners in facilities, it is an active process for patients to actually come to us. They truly struggle to come. But for that PPMV, it's a passive process. They literally have a relationship that's an ongoing relationship on an ongoing basis. And that's something they tap. It's very rich. We are particularly pleased that a lot of the work, a lot of that experience, a lot of that insight, again, is shaping some of the discussion we're having in country now around tax shifting. At least we are seeing a lot of some of the big moves to sort of decentralize, bring some of this level of care down that can be managed at this level. And it's even going to looking into the future, it's going to even be sort of a big area of change. At the moment, we are working on a process that is working with PPMV to actually build a tiered accreditation system. Because one of the things we learned just engaging with PPMV, trying to respond to our Amina, who is our customer, is that the term PPMV is actually a very sort of general term. Because within PPMV, many of them are medically qualified. But because of the policy environment, they don't want to come out. So even as we look at the sort of tiered accreditation process, we are going to start seeing things like medically qualified PPMVs, who will then be allowed to sort of deliver a higher level of care in a system that's truly functional. And this is how, at least the sort of former health system is working to actually incorporate where Amina truly gets her service. If you go to some states, for example, more than 65% of care, first level of care is actually at PPMV level. And so we are particularly excited that is happening. The other thing we've learned for Amina among the P's is the pricing. And I was particularly pleased today on some of the discussion, for example, that Michelle put on the table. We recognize very quickly that if you take a typical product, for example, say anti-malaria, the price between bringing it in, the manufacturer price, and actually the price that the Amina will get it, is 200%. And one of the things we're implementing now is what is called a direct-to-retail model. In the healthcare system in Nigeria, there's no direct to retail. What we have is a cascade system where there are many people down the chain. But if you look at other sectors, they have a very well-defined, well-developed direct to retail. And what we are seeing already in terms of quick result, we've seen the margins between sort of manufacturer price and consumer price actually drop massively. We are seeing margins drop from 200% to between 30 and 50%. And this is going to make a big difference in terms of Amina's ability to access care that she needs. Then when you look at promotion, again, the whole sort of big discussion around technology and how that makes knowledge available is something that's been discussed extensively in this conference. And it's going to increase because literally every Amina has her mobile phone. And we are using that in our business already to get great insight in terms of what they think, in terms of refill. And that's really, really increasing leaps and bounds. And these are sort of all experiences that are pulling together that when you look forward, we're going to see a future where the consumer really will be at the center of healthcare, whether we like it or not. And the challenge for us is actually to plug in and moving on. Looking at the sort of big policy space, I think looking at it, we really need to change our politics and the policy environment. If I was a politician addressing this group right now, and I wanted to talk about what I had to offer for health, I guess my pitch would be like this. Dear delegates of the 2017 Future of Health Conference, please vote for me as your governor. I'll give you 3,000 health centers. I'll give you more healthcare workers. I'll buy you medicines. There's no accountability in that. There's no way at the political space we are putting people at the center. What if I was to flip that round and I say, dear delegates of the 2017 Future of Health Conference, vote for me as your governor. Because I want to promise you that for the top 10 diseases that we suffer in this community, every woman, every girl, every boy, every man in this place, you will have free care. Just go to the nearest facility to you. Whether public, whether private, the government will pay for it. What do you think? Would that not make a difference? That would truly put people at the center of it. But the challenge is that the social contract we have right now makes that difficult. Because even for us sitting here, we are the experts that actually advise the politician. And our preference is always for inputs. Because inputs are easier. It's easier to count those health centers. But the problem with counting health centers is that actually there's no Amina in the mirror. And so it's easy also for the politician to default because there is no sort of social contract that you can touch and feel. And finally, I think just looking at my space, which is the third sector, the NGO sector, we all know that there's a lot of change happening in terms of the donor environment. And one of the things just reflecting is this a time or a future out there that where donor would actually focus more on actually paying for results rather than paying for input? Because overall, for years, what we've had is this focus on input. I just imagine a day where a partner will write a proposal and say to the donor, you know what, in this state, I want you to pay me, working with the government, for every woman who gets her full immunization, who brings her child in for the required health care, as distinct from, I give you a list of salaries, buildings, vehicles, so that the four-wheel drives will at least reduce. And that, in some way, will force us also to start thinking differently in how we construct our business and how we put our business out there. Thank you very much. Generally, what has been constructed over the years is that politicians tend to think more public-private sector, creating a dichotomy that doesn't exist. And the point I was making is that in the social contract we should drive from the 2017 edition, it's a social contract where politicians, where government officials will truly understand that as a citizen, I don't really care whether it's public or private. I actually want quality care. And if you ask most Nigerians, if you give us that choice, we may actually end up going to private. So if government create that, it will have a dual sort of goal or benefit. On the one part, it will expand access very massively. On the other part, it will actually now motivate the sort of public sector to start also upgrading their standards. And then generally, the two sides can compete. And then you can actually have that sort of game-changing sort of future we all desire.